Our next speaker is Professor Kim Foster. Kim is a mental health nurse and academic and is currently Professor and Head of Nursing and Midwifery in the Faculty of Health at the University of Canberra. Kim is a Director on the board of the Australian College of Mental Health Nurses and a Winston Churchill Fellow in the field of resilience and mental health. Please welcome Kim.
Thanks very much, Joanne, and thank you very much to the organising committee for inviting me here. It's been a fantastic day, and I'd also like to acknowledge the traditional owners of the land on which we meet here and pay respect to their elders past and present. As you can see, I'm going to be talking about one of my favourite topics, which is resilience. And, it's an interesting issue, resilience, I think. I've been working in this field now for quite some years, and the question that really intrigues me and that I think many of us are working towards is, how do we do well in the face of what is often very serious adversity and risk? So when we're working with people who are very ill, how can we work with them so that they don't just get through that, but they actually can thrive in the face of it? So it's a big question and it's a big issue. And so I want to talk to, what resilience is, what are the factors that constitute resilience, what's the evidence around that in the context of chronic illness, and then what are some of the strategies that we find work for people when they're struggling with illness. So that's what I'm really going to talk to today, and I'm going to come at it from a mental health perspective because that's my area, and I really have been working again in the whole field of co-occurring illness with colleagues in the general health sector, and I'm going to draw on some of our work where we've looked at comorbid mental and physical illness and what the issues are there. So from a mental health perspective, we know that people with mental illnesses, so serious mental illnesses like the psychoses and the high prevalence mental illnesses like depression and anxiety, have very high morbidity and mortality, and they have 15 to 30 years less life expectancy than the rest of the population. So it's a massive mortality risk. And we know that one of the major issues there is that there's a range of preventable risk factors for people with mental illness in respect of cardiovascular disease. So that's the greatest risk area for people with mental illness. There's a whole lot of reasons for that. And one of them, really is around, it is multifactorial, and many of these issues are. So it's not just one issue. Some of it's a genetic risk, some of it's lifestyle, some of it's, and a big part of it, is poorer access to and quality of physical health care for people with mental illness. And that's an issue we can do something about. Also, the effects of the mental illness on that person and the impact of the medications. So there are many, many factors there contributing to this. The other thing here that I think is important to highlight is that 18% of the population have a high prevalence mental illness. So a high prevalence mental illness is a depression, an anxiety or substance use problem. And of those, 43% have physical illness. So nearly half of those people with a mental illness are going to have a comorbid physical illness associated with it. And we know, as we've heard this morning, that when there are multiple illnesses, then the morbidity and mortality is substantially higher. So the other thing is, we've also heard, and I'm coming at this from the mental health perspective, but people who are depressed, this is a major risk factor for heart disease, stroke, type 2 diabetes, and to a lesser extent, osteoporosis. So that was from a systematic review in the Medical Journal of Australia. So you are familiar with many of these issues, and we've looked at this in Australia fairly recently. These are the most recent stats that I could find. But if you have a look there, if you can see up here, I've looked at mental illness as one of the chronic diseases, and we know that many mental illnesses are chronic, not all of them, but many. And if you have a look over here, this is just some of the stats that say if you've got a mental health problem, what's the proportion of chronic disease that can go with that. So if you have a look here, for people who are 0 to 44 years, so babies right through to middle age, that about half of them don't have a chronic disease, but about half of them have one or more. But if you look at age, and we know that age is a risk factor for many things, that changes markedly. If you've got a mental health problem, there's about 30% of people with a mental health problem will have one or more, up to 3. Look at the proportion up here. It's about 20% will have 3 comorbid physical illnesses alongside that. So when we talk about complexity, and we've heard a lot about that today, then we are talking from a mental health perspective a lot of complex issues. So why then would I look at this whole issue of resilience? And so I'm going to get to resilience in a minute, but if we have a look at this issue of mental health and chronic disease, this is from the National Centre of Disease Prevention and Health Promotion in the US. And so they had a look at some of the risk and protective factors for people who've got a primary mental health problem or a primary chronic disease issue. And so if you have a look here, then a risk factor for getting a mental health problem is having a chronic disease, as well as a whole lot of other factors like a family history, genetic risk, stressful life conditions, traumatic experiences, so that's abuse or accidents, etc., using illegal drugs or any form of drugs, childhood abuse, and lack of social support. And I'm going to come back to social support later because it's a big issue. And then if you look at chronic disease, they've categorised modifiable risk factors and those risk factors that we can't change. So when we look at this whole idea of risk and protection, it is a bit of a balance, and I'll put the scales here. People can have a lot of risk factors, but they can also have a lot of protective factors. And so what our job is, I think, in healthcare is to identify the risk factors, change the ones we can, and then try to build and improve the protective factors to offset it. And so when you look at the issue of resilience, then that's fundamentally what we're talking about. One of the things about resilience that I find interesting is that it's out there. It's out in our vernacular. We talk about it a lot. We sort of bandy it around a little bit, I think, that term. But what does it actually mean? And it is what we call a construct, it's an idea. It's not a thing as such. So there's lots of different views on what resilience is. So I'm going to share some of those with you, but there are different theoretical perspectives on what constitutes resilience. This is one that I and a colleague have written about, and there's a couple of things that I've highlighted here. To be resilient, there has to be risk. So we don't talk about resilience when things are going well and people are doing well, then that's not resilience. It's when there's a problem, when there's a major adversity, when there's a risk, when there's an illness, that's the context in which resilience can occur. So that can be a whole lot of challenges, including illness. And it's where people can not only maintain their wellbeing or restore it, but often they can grow it. So that's the other factor about resilience, is that the argument is that we can never go back to who we were before, that illness and health issues fundamentally change us. And so how can we, in the face of that, how can we not only get through that, but how can we actually in some way grow out of it? So it's a big ask to have positive outcomes, positive life satisfaction and health outcomes in the face of what is really difficult health conditions. So another thing about resilience is that it's not static. So that we can measure resilience. There are lots of measures for resilience. We can measure resilient factors, but it is a notion of being dynamic, so that in one context, for example, there are different types of resilience. So there's mental resilience, there's physical resilience, there's resilience at work, there's resilience in our personal life. So there are many dimensions to what constitutes resilience. And it is dynamic, it can shift and change. The other thing I think is really interesting, and I think this is interesting for us as health professionals, is a lot of the early work talked about us as individuals. You know, there's resilient people and there's not resilient people. But we've moved on from that, and Michael Unger talks a lot about the fact that it's not just about us. It's actually about our environment. So his definition says it's the capacity of us as individuals to navigate our way to health-sustaining resources. And it's a condition of our family and our community and our culture to provide those resources and experiences in ways that are meaningful to that person. So if you think about that notion, there's two things there. One is about us as individuals and our risk factors and protective factors. And the other is, what are the resources out there that are available to support us in being resilient? And I think in healthcare, that's where we come in. You know, what are the resources we provide for people to help them? Now, the other good news, I guess, is early on they used to talk about these super people who were resilient and everyone else wasn't. But what we've learned is that these abilities are not necessarily just innate. They're not just about the individual. We can learn to be more resilient. And the other thing, the other point here, as I mentioned before, is this idea of not just getting through illness, but actually being able to thrive. So I'm going to talk from the perspective of what some of the evidence is, and then some of the studies that we've done where people have talked about some of this. So this is a recent integrative review that, or it was actually a systematic review that looked at chronic illness and resilience. And what they found with the studies that they looked at was those that had higher resilience, who had a chronic illness, had less depression and anxiety and somatic or physical symptoms. They had better quality of life. Their health behaviour was more positive, and they were more focused on health promotion. And that resilience, interestingly, could be a determinant of self-care, so that if someone was more resilient, that they might actually engage more in self-care. So on the other end, those with lower resilience had a worsening of their disease, their illness. They had more severe depression. And for people with diabetes, they had difficulty controlling their glycemic levels. So that's just an overview of some of the studies that have been done around that. So the interesting thing then is, I'm going to draw on some of the studies we've done. These are two studies that are with PhD students that I've worked with. One is from the perspective of what's the mental health of people with traumatic physical injury, and we followed some of those people over time. And the other is an issue that was raised earlier, and one of the areas that I work in a lot is around families and family carers, and so resilience in families where a person has chronic pain. So some really interesting findings. So with Tennille Wiseman's study, which was the top one on depression, anxiety and stress, we followed 201 people over a 2-year period and measured their depression, anxiety and stress following the injury, and also talked with a number of them. And then in Karen West's study, 31 families where a person had chronic pain, so 67 people in those families, we asked them about, and we measured their resilience and their pain and social support and a whole lot of other things. So, pressing the wrong button there. So one of the things, this was from Tennille Wiseman's study, and this injury is an acute event, of course, but it often has a lot of chronic and long-term disabilities. And this was Greg, and he talked about what it was like right at the beginning, that the whole shock that he felt. And it was particularly interesting because he had that comment about boys will be boys, and, you know, I thought I'd just get up and get going. And I was shocked because I didn't bounce back. And bouncing back, of course, is one of the common ways that we think of resilience. But in fact, what some people would argue is we never bounce back, as I said before, that we bounce forward in some way. And so he's 53. This was 2 years after injury that we were talking with him, and he got crushed at work between a lifter and a truck. So he had really significant abdominal injuries. He'd had a lot of surgery, he had a lot of scarring, and he'd scored high for depression and anxiety at 6 months post-injury, and so that's why we'd followed up with him. And a lot of the participants in this study talked about coming to this really unpleasant realisation after discharge that this was going to have a really long-term impact on their lives and that they hadn't been able to go back to work. They hadn't been able to resume their normal lives. They'd had ongoing pain. And for nearly all of the male participants in this study, they were suicidal. So, and I'm going to come back to illustrate some of the issues I talked to as we go through. Now, this is a systematic review that looked at what are the risk and protective factors, so the resilience factors, in chronic illness, and they categorised them this way. And so I'm just going to walk through those fairly quickly and then come back to them at the end when we look at strategies then. So this was Stewart and Nguyen, and they reviewed 52 studies around resilience factors in illness. And so you can see here that they came up with a number of terms. We've already heard many of these today. So factors like self-efficacy, so people feeling like they have the ability to alter things that happen to them. Very similar to the notion of internal locus of control, that we are able to, make success in our own life, that we can control things from our perspective. Optimism, self-esteem, and this interesting idea about hardiness. And if you think about hardiness early on in the piece when we were looking at resilience in not me, but people before me, were saying that, there's the hardy personality, the person who can stoically get through everything. We've moved on a bit from that notion, but hardiness is about accepting challenges in a positive way. So you can see here that what the evidence shows is that those who've got those factors, those characteristics, which are partly personality and partly about how we think about things, have these positive outcomes. And so an example of a couple of these, this optimism and the mastery. Greg, again, who I was just talking about, we asked him about a recovery, and he said, well, I'm hoping for it and it will happen. I'm pretty positive. I know my body before, it worked really well. There's no reason why it shouldn't work okay later on. I've got expectations. So his frame of viewing this was positive. Noel was a younger man who's 39, and he had had a motor vehicle collision, and he'd had fractured skull and facial injuries and scarring. And he talked about the accident and the injury, and he said, I'm feeling pretty lucky to be here. I keep the steering wheel up on the wall to remind me of what I've come through. So some people would say you wouldn't want to look at the steering wheel ever again, but for him, it was about, it reminds me I got through it, so I can move on. So if we think, coming back to the systematic review, social support. In many, many studies on resilience and how people can overcome all sorts of adversity, this is one of the major factors that comes up time and again. It's highly predictive of resilience. And so social support is not just family and friends and the community, but it's also health professionals. And many people talk about the fact that having health professionals interested in their lives and in their care is a strong factor that helps them get through illness. And that they talk about that it's important to successfully living with illness. So here's another couple of examples from Karen West's study looking at chronic pain and social support. It was a really big factor in her study, and particularly it was about partners. And so again, that's come up in many other studies on resilience, that the higher, for these group of people in this study, high resilience was positively correlated with high social support and higher mental health. So, you can see a couple of the quotes here. It was about family, it was about friends, and it was particularly about partners. So in terms of coping strategies, and again, this came out of the review, spirituality is a really big, faith is a really big resilience factor for many people. And the other thing is sense of coherence. So being confident that you can, the environment is predictable and things will work out. And the last thing in this review was around benefit finding. So benefit finding is an interesting one because, and it has come up in several studies, it's where people find meaning within the illness and where they view it as a learning experience. It's a really interesting idea, and a lot of people will talk about that who've got chronic illness. So in terms of all of that then, what works and what can we do, as particularly from a nursing perspective, to help build protective factors and resilience? And the interesting thing is, Stuart and Yuen said in their review, surprisingly, there were no mentions of healthcare professionals' roles in contributing to resilience in the physically ill in the studies that they reviewed. It's really not talked about a lot. And particularly in Tennille's study, there was a lot of mention of the fact that if someone had asked me, I would have talked about it, but nobody really asks. And so this is an interesting issue for us to have a look at. I've just picked out 4 key areas around what are the strategies that we know can work and what can we do as nurses. A really big one is working to build social support for that person. If there's nothing else that occurs, having that factor there is incredibly protective, particularly including partners and family in care and in care decisions and involving them in consultations and in meetings. Peer support is very supportive for a lot of people, and co-facilitating with a consumer in care provision has had really positive outcomes in the literature. And also things like community groups. A lot of the participants in our studies talked about Alcoholics Anonymous, they talked about church, they talked about community groups that gave them a lot of strength. So if you can encourage people to actually engage with or remain engaged with those, very protective. So the other thing is, how can we strengthen self-efficacy? One of the things, and you can see them here, one of the things I just want to pick up on, which I think Rosemary talked about earlier, is anticipatory guidance. If we can talk with people about what they can expect at different stages of the illness, they can anticipate the changes, and it makes people feel like they have more control over things, and they don't get so sidelined by or shocked by what happens. So it really does help those frameworks. And also the other thing is, we focus a lot on what's going wrong, but if we can focus on what's going right for them, what's working for them and with their families, what can they do more of that is going well, can help. And also, and I think Ray talked to this and several other people, it's about having the talk. It's talking, having the discussion about emotions. And one of the participants said, having emotional talk, let's talk about those feelings. Screening for risk. In Tennille Wiseman's study, out of her study now, they're screening all injury patients who come into that health service for depression, anxiety and stress now, so that they can prevent and early intervene. And the last one, and I think it's a really important one, and many, many people talk about this, maintaining hope. And sometimes we have to hold hope for people when they don't have it for themselves, and also encourage people to develop optimism. Now, not all of us are naturally optimistic, but there are strategies that we can use to help people to think of other challenging situations that they've mastered, and use those skills in this situation to look at the positives of what's going on as well as what's negative, and to set goals and to aim to achieve them. All of those strategies can help. And I just wanted to leave you with this last one. This is not about patients or consumers, it's about us. And Karen Lee Edwards said, despite the unrelenting and demanding nature of nursing, many have not succumbed to the pressure of the work, but have continued to remain enthusiastic, empathic and skilled. And I think one of the things here, we ask a lot of us as nurses and health professionals, but the work we do is incredibly important, and we need to also look after ourselves. And I know that Julie's going to talk a bit more to clinical supervision and things like that later, but I just wanted to leave you with that. And there's some references. Thanks.
Got a couple of minutes for questions, but we'll have to restrict it to 1 or 2. But I'm sure Kim will make herself available at lunchtime if anybody's got any other questions. Questions? No? One?
Just one up.
It's bringing up everywhere.
Hi, Sue Vandenberg, credentialed mental health nurse in private practice. I just wanted to make a comment which is relevant to all of our presenters today, and it's becoming more and more aware, or I'm becoming more and more aware of how resilient people need to be who have a chronic illness in dealing with bureaucracy, particularly Centrelink
Yes.
and Medicare. I have two people that I saw in the last week who have been driven to distraction because they're caught between Centrelink and Job Network and DSP and Newstart, and they go into the Centrelink office, which they're progressively being decreased. They're told to go home, they have to do it online, or they have to do it by phone. They're on hold for 7 hours. These are people who already have chronic physical illnesses and chronic mental illnesses. And I just want to make a comment that the system seems to be set up to aggravate people's health instead of improving it. And I don't know if anything can be done about it, but I just really wanted to make that comment that in some cases, that's one of the things that we just can't do anything about, no matter how hard we try. I mean, I've advocated for people through Centrelink, and it drives me crazy.
Yeah.
And I really feel for my clients. So I just wanted to make that comment.
Yeah, no. I think it picks up on one of the issues that we were talking about earlier about care coordination. I mean, one of the things that's really coming out of the work we've been doing is that it stops, after hospital there's kind of nothing. And then unless people find their way to the GPs, which often have worked really well, or they manage to have connections with around Centrelink, etc., then they're kind of out there in the breeze. And so one of the things that we've been looking at is having a family care coordinator role that extends beyond discharge and sort of can follow people over that journey and help them navigate some of it. Yeah. Yeah.
I think there was one more question, was there? No?
Hi, I'm Louisa Sasko from Mental Health, Drug and Alcohol, a CNC in Northern Sydney. I'm actually very interested in this topic, and I was actually wondering if there's any planning or programs being developed in a preventative measure in schooling, in health education of children, because it would be good to perhaps start building resilience in our people at a young age, either before or perhaps while some young children are suffering perhaps trauma or disturbing things, but you're starting to build resilience and showing them, even though they may be little, that there's places they can go to navigate, and try to have some measure of control over their wellness.
Yep.
And is that being looked at?
Yeah, no, that's right. So a couple of things to say about that. There's the Child Illness and Resilience Program that's running through the Hunter region, and that's for children with chronic illnesses. And so if you go online, that they've done a whole lot of resources and they're working with a whole lot of families in that area, and it's a national initiative. The other thing is a lot of schools are running resilience programs. I think there's one called the Resilience Donut is a program that they use a lot in schools. So it's a really good point. The earlier you can help kids learn how they can access things and how they can help themselves, the better. Yeah.